A female Miss ABC of age 21 years came to the casualty with chief complaints of swelling in the neck for past 3 years, cough with expectoration for past 2 months, and fever for the past 2 days. Patient was apparently asymptomatic 3 years ago, following which she noticed a swelling over the left side of the neck, which was insidious in onset, not associated with pain, initially smaller in size, and now has progressed to the current size. She also had history of fever along with the development of swelling, which was high grade, associated with chills and rigor, with evening rise of temperature and followed by night sweats. However, she says she took medications, which is paracetamol 650 mg, and fever subsided after taking those medications. She also noticed multiple swellings on the right side of neck and bilateral axillary regions, which were initially small and progressed to current size, with subsequent episodes of fever, which occurred every 5 to 7 days after each fever spike over the past 2 months. She also complains of cough with expectoration for past 2 months, which was insidious in onset, scanty sputum production, which was pale white in color. It is not associated with blood in sputum or shortness of breath. Currently, patient has fever for past 2 days, which was high grade, associated with chills and rigor, with evening rise of temperature and night sweats, with no aggravating or relieving factors. There is no history of loss of appetite or significant weight loss. However, she says her clothes have become quite loose than before in the past 2 months. There is no history of skin rashes or change in voice. There is no history of throat pain or difficulty in swallowing. There is no history of nasal discharge, mouth breathing, or bleeding from the nose. There is no history of facial fullness, headache, or facial pain. There is no history of drooping of eyelids. There is no history of hard of hearing or ear discharge. No history of pain or increase in size of swelling in relation to food intake. No history of movement of swelling while swallowing. No history of sudden increase in size of the swelling. There is no history of wound or ulcers over the scalp region. There is no history of wound or ulcers in the lips or loosening of teeth in the oral cavity. There is no history of swelling or ulcer over the breast. No history of abdominal distension, abdominal distension or abdominal swelling or swelling over the groin. No history of ulcers or growths over the genital area. There is no history of back pain or fractures or headache or seizures. Past history. There's history of similar illness 3 years ago for which he was started on anti-tuberculosis treatment and stopped after 2 weeks. He was started on ATT because sputum sample was negative for CBNAT, but on FNAC they found chronic granulomatous lymphangitis. But the reason for stopping anti-tuberculosis treatment was unknown from an local hospital. No history of exposure to tuberculosis patients in the past. There is no history of irradiation in the past. The patient is not a known case of thyroid disorders, seizures, or asthma. Family history, there's no history of similar illness in the family. No history of patient with TB, tuberculosis in the family. No history of any malignancies running in the family. The family belongs to class 3 socioeconomic status. Personal history, she consumes a mixed diet. The patient has a normal bowel and bladder habits. She has normal sleep-wake cycle. She is not addicted to alcohol, tobacco, and there is no history of any substance abuse. There is no history of any promiscuous sexual activity. Summary, a female of 21 years of age presented with complaints of swelling of the left side of neck for 3 years, cough with expectoration for 2 months, and fever for 2 days. She has had multiple episodes of fever over past 2 months, along with the development of multiple small swellings on the right side of the neck and bilateral axillary region. She has history of loosening of clothes. She had similar complaints 3 years ago for which she was started on anti-tuberculosis treatment. However, FNAC of a neck lymph node showed chronic granulomatous lymphangitis, even though CBNAT was negative for a sputum sample. However, ATT was stopped after 2 weeks of treatment, the reason for which was unknown. After the history, my probable diagnosis would be tubercular cervical lymphadenopathy, a primary malignant lymphoma, and secondaries from an occult primary.
Yeah, Akash, can you come
Yes,
back
sir.
to the first slide?
Yes, sir.
So with your information, she has neck swelling since last 3 years.
Yes, sir.
Okay.
Yes, sir.
And that history of having treated with FNC report and treated with EKT is 3 years back
Yes, sir.
for 2 weeks.
Sir, treated with ATT is 2 months back, sir, when she had cough with expectoration, sir, persistent cough with expectoration, and along with swelling, sir.
Okay, it was 2 months back from
Yes,
this
sir.
history. Okay,
Yes,
okay,
sir.
okay. But she has a swelling since the last 3 years.
Yes, sir.
Okay. In the beginning, you mentioned that patient came to casualty.
Yes, sir.
Okay, what is casualty means?
So the emergency department, sir.
Okay, so the lady who has a swelling last 3 years, what made her to come to casualty, and you have taken the case from the casualty and presenting?
So she had a high grade fever for which she had presented, sir. The fever was about
Okay.
103 degrees Fahrenheit. Sir.
Okay, so
When
her
following
visit to the
that,
hospital to casualty was because of fever.
yes, sir.
Okay, so when you got the history, you got all of these
Yes, sir.
details.
Yes.
Okay, what is the importance of knowing this?
Sorry, sir.
What is the importance of knowing this? So why am I asking that? Why you are mentioning that patient has come to casualty for a disease which there is a duration of 3 years?
So to differentiate whether it is an acute onset or a chronic onset, sir.
Yeah, with the history, it says that it is chronic because she has a swelling of 3 years duration.
Yes, sir.
Okay, so the idea is it is an acute manifestation of a chronic illness.
Chronic disease. Yes, sir.
Acute manifestation of a chronic illness. There are selected chronic illnesses which
Yes,
can
sir.
present as acute onset.
Yes, sir.
If you think in terms of tuberculosis, which is a chronic disease,
yes, sir.
Can you mention just acute manifestations of a tuberculosis or tuberculous disease?
There may be sudden onset of lymphadenopathy, sir.
It will not come suddenly for tuberculosis.
Okay,
Mention few acute problems where a patient can visit casualty for a chronic illness like tuberculosis.
So it may be due to a secondary infection because tuberculosis is an immunocompromising condition, sir.
Okay, means patient may present with an abscess.
Yes, sir.
Okay, one.
Or the presence of a sinus formation, sir. Over
That
the
is,
neck.
they may not come to casualty. They will come as an elective to your OPD. I'm
Yes,
talking about emergencies.
Yes, sir.
Second, what I expected was hemoptysis.
Hemoptysis. Okay,
If it is a pulmonary tuberculosis with a lesion there, the patient may come to casualty with a hemoptysis.
hemoptysis. Yes, sir.
Yeah, hemoptysis. Second. Third, patient may come with a history of breathlessness and chest
Breathlessness.
pain.
Acute onset breathlessness. Yes, sir.
What? Due to what? What may be the underlying tubercular disease which will present as breathlessness and chest pain?
It may be due to a pleural effusion, sir.
Pleural effusion. That is a commonest way of presentation.
Yes, sir.
So patient may visit casualty for the evidence of pleural effusion, where presents as breathlessness.
Yes.
And may be associated with chest pain.
Yes, sir.
Okay, so the patient may present a casualty in a cachexic form.
Nutritional
cachexia may be brought by his relatives.
Yes, sir.
Because you have taken in the presentation casualty, just I wanted to highlight these few points.
Yes, sir.
Okay, in what way they can present as an acute manifestation, even if it is a tuberculosis.
Yes, sir.
Is it not?
Yes, sir.
Okay. Can you, this case, because you have highlighted history of fever, yes, so
sir.
Can it be some other disease with a neck swelling like this, a long history, other than tuberculosis?
So it could be a Hodgkin's lymphoma where there is remittent fever.
Lymphoma. What are if a patient of lymphoma has fever? What is that called? What are those symptoms called?
B symptoms, sir.
B symptoms. Okay, you highlighted that patient had a rigors, had a sweating and a fever.
Yes, sir. Yes, sir.
Could be these symptoms, these symptoms may be one of the manifestation of the lymphoma. So
Yes,
that
sir.
also on history you have mentioned in the second possibility as lymphoma. So that also fits into that.
Yes, sir.
And you said you did not mention swelling in the neck, just you mentioned. You should have mentioned where exactly she must have noticed. In the left side,
Okay. Yes.
upper part, lower part, mid part of the neck, anterior, posterior. They will understand if you ask them in their own words.
Yes,
So
sir.
in this case, what was the like history? Lateral part of the neck, upper, lower neck,
Yes. In the upper left side neck, sir. Upper
upper
part
neck,
of the left side of the neck.
upper
Yes.
part of the neck. Does it matter to know whether it is upper part of the neck or lower part of the neck?
Yes, sir. Because if it is in the lower part of the neck, it may involve the supraclavicular lymph nodes.
No, no, I'm not asking what lymph nodes. How does it
Yes.
matter in the heart history level? History level.
Mhm.
How does it matter
So,
to know whether it is upper part of the neck or lower part of the neck? You can suspect particular diseases. If the
yes, sir.
patient says it is upper part of the neck, likely that she may be having some source from a aerodigestive tract,
Thyroidigestive tract. Yes, sir.
upper aerodigestive tract. If she says she has noticed lower part of the neck, likely that there can be some disease in the chest.
Chest wall. Yes, sir.
In the chest. You got the point.
Yes,
Roughly,
sir.
it will direct you to find out what may be the primary source for that lymph node, whether it is a benign disease or a malignant disease,
Malignant.
whatever it
Yes,
is.
sir. Yes.
Whatever it is. So by asking just is it upper part or lower part, it will direct you.
Yes, sir.
Probably where is the source for that lymph node. Okay,
Okay,
so
sir.
it is
Yes,
important to know upper or lower part.
yes, sir.
This case, you said 2 months she has got a history of cough with expectoration.
Yes, sir.
So do you want to correlate that with the neck swelling?
It may be probably because of pharyngitis, sir, which may have caused the acute inflammation of the lymph nodes on either side, sir.
No, this is history is 3 years pertaining
Yes,
to
sir.
the node, pertaining to the swelling. 3 years.
Yes, sir.
So having cough with expectoration last 2 months, so does it correlate anything with the neck swelling?
No, sir.
Why not? Why you cannot put it as a tuberculosis still? Yeah, earlier, whatever the swelling she had, that is also tuberculosis. She has not been treated for XYZ reasons.
Yes, sir.
And now probably the disease has extended and it has involved the lung, and now she has a cough with expectoration, and that is the commonest cause what we see in our country.
Yes, sir.
Is it not? So
Yes.
definitely we can correlate her cough with expectoration. We cannot just ignore that symptom.
Okay, sir.
Okay.
Yes, sir.
Okay, coming to the treatment history, what you mentioned, you said all those terminologies that you came to know by reading her reports, or patient herself who said all those terminologies.
So patient was not able to tell, sir. It was from the
Then
reports
how
that I
did
have
you come to
mentioned.
know that you saw the reports?
Yes, sir.
That you should mention in the history.
Okay, sir.
If you have come out with such like wordings, like patient has been treated with AKT or ATT, and she CB net was negative, and FNAC report was like this. If you are reading these medical terms,
Yes, sir.
you should highlight whether patient herself mentioned these words, or did
Okay.
you check the reports and you came to know about these terminologies from the report.
Okay, sir.
You need to mention that.
Yes, sir.
Okay, so this you could see in the report, her reports.
Yes, sir. Yes, sir.
Okay. If FNAC has given it as a chronic granulomatous lymphangitis, I don't know whether you are right mentioning that lymphangitis. Okay. So
Yes, sir.
what is your impression as a medical person?
So it brings to me the idea of some granulomatous diseases such as TB, sarcoidosis, syphilis, like that, sir.
Okay. Fine. Yeah, don't keep only tuberculosis. Commonest is tuberculosis.
Yes, sir.
Yeah, sarcoidosis also is one of the other possibilities. Syphilis nowadays we don't put in the diagnosis.
Yes, sir. Okay, sir.
Okay,
Yes,
fine.
sir.
Can you expect with a patient who has come to you for a neck swelling, which you are thinking in terms of tuberculosis, can
Yes,
you
sir.
expect if you do sputum for CB net, expect that to be positive?
So if there is exchange So if the primary is a pulmonary, if there is a primary pulmonary tuberculosis which has
No,
extended
not
to the
if.
lymph nodes, then
I'm
we can
giving a
expect a
case.
positive. Yes, sir.
No, not if lung. If lung is involved, I would have not asked.
Yes, sir.
If a patient has come to you with a neck swelling and you are suspecting tubercular lymphadenitis,
Yes, sir.
if you do sputum for CBNet, will you expect that to be positive?
Yes, sir. If the infection has passed on from the tonsils into the lymph nodes, then it may be positive, sir.
Why, if it is from tonsillar tuberculosis extending to the lymph node, why sputum CBNet or AFB will be positive? It need not be.
Okay,
Only
sir.
when there is a pulmonary
Okay, sir.
tuberculosis, then we expect these tests to be positive.
Okay,
If
sir.
it is a lymph node disease, wherein the commonest source of infection to the nodal disease is through the tonsils,
Through the tonsils. Yes, sir.
sputum may not be positive.
Okay, sir.
So that may not be the right way of excluding tuberculosis when there is a lymph or a nodal disease, nodal tubercular disease.
Yes, sir.
You understood?
Yes, sir.
So if it is a pulmonary tuberculosis, even then all 100 pulmonary tuberculosis may not be positive for CBNet or AFB in the sputum. All 100 may not be positive.
Okay, sir.
If it is positive, we take it. If it is negative, doesn't rule out tuberculosis.
Okay, sir.
Okay?
Yes, sir.
Okay. You have mentioned so many, the no history, almost 2 slides you have put. So I hope you wanted to rule out all the primary source for that lymph node. Am I right?
Yes, sir.
Including all benign diseases and malignant diseases.
Yes, sir. Yes.
Okay. Among them, I could not understand what is this facial fullness, headache and facial pain and drooping of eyelids. What was that idea of asking that in this patient?
So in case of sinus, if there is any malignant infiltration of the sinuses, sir, there may be facial fullness or facial pain and headaches, sir.
That she would have had other symptoms also, no?
Yes, sir.
And 3 years it will not stay there just like that.
Yes, sir.
What is a drooping of eyelids?
So if there is any infiltration of the cervical sympathetic chain, we can expect Horner's syndrome, sir.
But
Where there will be
her symptoms is upper part of the neck. Swelling is in
yes,
the
sir.
upper part of the neck. Does it cause a
Yes.
Horner syndrome?
No, sir.
So you
Lower
should use
part
your
of the
head
neck.
here.
Okay,
If
sir.
the swelling would have been the lower part of the neck, then you can explain
Yes.
her Horner syndrome. Just like that, you should
Okay.
not mention all the points.
Okay, sir.
And then why is this movement of swelling with a deglutition here you mentioned in the history? It's a lateral swelling and the upper part of the neck.
Yes, sir.
So anything you are thinking in terms of thyroid, and do you ask that history movement with the deglutition when there is presentation of a thyroid? You don't. So unnecessarily, and sudden increase in the size. What is that condition you expect? Sudden increase in the size or decrease?
Suppose if there is a malignancy, sir, or any hemorrhage into the swelling, sir.
That is there, you would have presented, no?
Yes, yes, sir.
And she would have told also.
Yes, sir.
So what I want to highlight, you should avoid this mentioning so many. It will not fetch you anything. In fact, it will dilute the issues. Okay.
Okay, sir. Yes.
And ulcers, scars. If it is there, you should mention.
Okay, sir.
Okay.
Yes, sir.
Okay. So at history, you felt it is probably still tuberculosis.
Yes, sir.
Okay. What is the commonest neck swelling you come across in a young patient like this, 20 years? Commonest neck swellings.
Commonest would be a tubercular lymphadenitis, sir. Acute tubercular lymphadenitis.
Not tuberculosis. Anatomically, you should tell. What is the commonest neck swelling?
Thyroglossus.
It's a lymph node swelling. No, it's a lymph node swellings are commonest.
Okay.
Lymph node swellings are the commonest. Okay. Yeah.
Yes,
next slide. Next slide. Okay. Next slide. Put that diagnosis slide you mentioned at history level. Okay.
Yes, sir.
I would be very happy if if you mention the possibilities at history level. Because she has come, young lady, she has come with a lateral neck swelling. I'm thinking in terms of a lymph node swelling. You should give the anatomical diagnosis first.
Okay, sir.
Looks like it's a lymph node swelling. What are the points to on history that it is a lymph node swelling? It's a young girl presenting with a lateral neck swelling in the upper
Lateral
part.
neck swelling. Yes.
Yes. So that is a commonest swelling, lymph node swelling. So what is pathologically probably the disease she has? Because she has history of cough, fever, and 3 years duration, and having treated with AKT, probably it is tubercular lymphadenopathy.
Yes, sir.
Okay. So second
Yes.
possibility, because it is persistent, you cannot rule out tuberculosis because she has not completed her course.
Yes, sir. Yes.
If she would have completed her course of duration of AKT, and in spite of that it is persistent, then probably you would have not thought of tuberculosis.
Yes, sir.
You would have thought of some other disease which would
Some
have
other
missed in the
disease.
beginning. In
Yes.
that case, you should classify into two things at history level. Either it is a primary malignant disease of the lymph node, which we said is
Yes.
lymphoma, or it is
Yes,
a
sir.
secondary deposit in the
Secondary.
lymph node. That
Yes,
becomes
sir.
a pathological diagnosis.
Pathology. Yes, sir.
So at history, you should put it as two entities. One, anatomically, it is a lymph node, which all
sir.
the points are in favor. Pathologically, two possibilities you should keep. One, tuberculosis first. Second, either a malignant, the disease involving the lymph node, that is lymphoma, or a secondary deposits in the lymph node.
Yes.
You understood?
Yes.
So this is at history level. So we'll see how the clinical findings fits into presentation, examination.
Yes. After obtaining informed verbal consent from the patient, she was examined in a Yes, sir. She was examined in a well-lit room. The patient is in a sitting position and she is oriented.
One second.
Yes,
at history, you mentioned she had noticed swelling in the axilla and where else you said opposite neck, right
Yes,
side.
Sir. Yes.
She herself has noticed swelling in the axilla.
Yes, sir. While bathing, she has said she noticed the swelling, sir.
She said,
yes, sir.
Okay, fine. Continue.
Yes, sir. After obtaining informed verbal consent from the patient, she was examined in a well-lit room. The patient is in a sitting position, oriented to time, place, and person. She is moderately built and nourished. There is mild pallor is present. Generalized lymphadenopathy is present. There is no icterus, cyanosis, clubbing, or pedal edema. Vitals, her temperature is about 101 degrees Fahrenheit. Her pulse rate is 108 beats per minute, which is full in volume, having no specific character, no radial or radiofemoral delay. Her blood pressure is 110/70 millimeters of mercury in the right arm in the sitting position. Her respiratory rate is about 17 cycles per minute, which is thoraco-abdominal in character. Whole body examination. On the scalp, there are no ulcers or swellings. Eyes, there is no double vision or drooping of eyelids. There is no discoloration or swelling over the eyelids.
Aakash, anything positive here in this slide?
No, sir.
Okay, next slide.
Yes, sir. This is the photo of
back. Okay. What is this pulse full volume? Means what? What is the meaning of that?
I meant there is a hyperkinetic pulse.
Means you mean it is bounding pulse?
No, sir.
Then what is this full volume means what?
There is no. I wanted to mean tachycardia.
Tachycardia is rate.
Yes, sir.
It is a volume. Rate, rhythm, volume, character of the wall. That is how we describe a pulse, no?
Yes, sir.
I don't know. You are not supposed to use all funny words. And in this case, what is relevant pertaining to pulse? Because she is febrile, we expected tachycardia, which you have mentioned here.
Yes, sir.
You got the point.
Yes,
remaining things may not become much important pertaining to this. Otherwise, you will be inviting unnecessary discussion like this full volume.
Okay, sir.
You got the point?
Yes, sir.
Okay. What is the idea of mentioning icterus in this patient?
Sir, if there is involvement of the liver, sir, maybe because
what? By what?
Maybe by because what? Of the Hodgkin's, if there is a malignancy involved and the liver is involved, it may cause icterus, sir. or because she has already been on antituberculous treatment, which are mostly hepatitis.
I will accept your answer because AKT can cause hepatitis and can cause icterus, not
Yes,
lymphoma.
okay, sir.
Even if it is a Hodgkin's, the NHL and involves liver, they rarely cause jaundice.
Okay, sir.
Okay, so the icterus can be explained because patient has been treated with AKT, maybe
Yes,
drug-induced hepatitis and jaundice. What is the
yes,
idea
sir.
of mentioning cyanosis and clubbing?
Uh, if the patient has any mediastinal lymphadenopathy, sir,
How it
there
will
may be
cause cyanosis and clubbing?
the mediastinal lymph nodes may compress over the bronchus, sir,
Anyway,
and there may,
you are stretching too much. I expected only pulmonary tuberculosis.
okay, sir.
Okay, because she has cough, which we have discussed, cough and expectoration and lymph node, pulmonary tuberculosis results in
Yes,
cyanosis and clubbing.
yes, sir.
Why that you are stretching too much mediastinal lymph nodes, causing compression of something and then causing all of this? Huh?
Yes, sir.
Yeah, simple. No? Pulmonary tuberculosis can have clubbing and
Okay,
cyanosis.
yes,
You
sir.
got it?
Yes, sir.
Okay, so what are the points here? She is febrile and she has tachycardia.
Yes, sir.
Okay, local examination.
Local examination of the left side of neck.
Yeah, you put those photographs.
Yes,
You
sir.
describe there only.
So there's a fullness over the right side of the neck. In the upper part, there's no the skin over the swelling is normal, sir, and there are no scars, sinuses, or dilated veins over the swelling, sir. It is a swelling of size 3 into 4 centimeters, which is ovoid in shape, non-tender, rubbery in consistency, having a lobular surface. It is not fixed to the skin and it is mobile, sir. Whereas, but on extension or turning the head against resistance to the opposite side, the swelling becomes less prominent, sir.
Yeah, describe the other one, the left one.
Yes, sir.
The right.
Yes. The swelling present over the left side of the neck. There is fullness present over the left upper part of the neck. There is no, the skin of the swelling is normal and there are no scars, sinuses, or dilated veins over the swelling. The left side of the neck, the size of the swelling is about 4 into 5 centimeters, ovoid in shape, non-tender, having a rubbery consistency, and there is a lobular surface. It is not fixed to the skin, and on turning the head towards the opposite side against resistance, the swelling becomes less prominent, and there is restricted mobility on movement of the head. So.
You have finished all inspection, palpation, everything. Want
Yes,
to
sir.
read your slides to complete the presentation? Next slide. Want to read your slides?
Yes, sir.
Anything you have left?
There are also multiple discrete swellings on both sides, sir, but they are not very much palpable, sir. There is very, very small, sir.
You said they are not palpable and they are small. Means what? How did you find out then?
I had only one. I checked for swelling over the left side of neck. There was one big swelling, sir, and followed by there were one more swelling, sir.
Okay. Anyway, I don't want to mention the details how exactly swelling should be presented. Yeah, inspection, you mentioned few points. The surface, you should not mention it as a lobular here because it's
Okay,
a small single swellings on either side. Is
yes,
it
sir.
smooth or not smooth? If you say
Okay, sir.
lobulated surface, then it is not a smooth surface. Is it like that in this case?
No, sir.
So they are smooth surface. Both of them have got a smooth surface.
Okay, sir.
Okay. So are they mobile freely?
There's some restricted mobility, sir. It is not
No,
completely.
that is after
mobile.
putting the muscle into contraction. Before
Yes,
that, are they mobile?
Yes, sir.
So don't use the words not fixed and mobile. Use one
Okay,
of
sir.
them. Best
Okay,
is
sir.
mention what is there.
Okay, sir.
Mobile and not fixed are not same.
Yes.
Okay, so it's a mobile
Yes.
swelling.
Yes, sir.
Okay, so on contraction of the muscle, what happens? It becomes less prominent.
Yes, sir.
Okay, fine. And left side, it is in the upper part of the neck, and right side, it is in the posterior triangle. If I can
Yes,
understand that photograph.
Yes, sir.
Okay, it is in the posterior triangle of the neck. Okay. Yeah, next. Any other swellings you have palpated in the neck? Any other than these two?
No, sir. In the neck, that is also.
Okay, fine. Oh, your examination is complete, or you want to present little more? Anything else?
So there is also swelling, some small swellings in the axillary regions, the bilateral axillary region.
In the head and neck first. You finish up that and then you come to the axilla. Anything else you want to present there?
No, sir. Nothing more in the head and neck.
See, whenever you have a case like this where there are swellings in the neck bilaterally and you have given so beautiful history, your examination is incomplete unless you examine the what?
Oral cavity, sir.
Yeah, oral cavity you have to mention. Your examination is incomplete unless you examine the oral cavity in this case.
I mentioned, sir. Shall I read the oral cavities?
No, whole body. I don't appreciate this whole body examination. Here, okay, exclusively after examining the neck.
Okay, sir.
You have to highlight under the heading of examination of the oral cavity, you need to mention few points.
Okay, sir.
Okay. After the neck presentation.
Okay, sir.
It is very specific. Means you have put your efforts to find out is there any primary source in the oral cavity in the form of a benign disease or a malignant disease, whatever it is.
Malignant disease. Yes, sir.
Whatever. We are not labeling anything, whatever. What is that you will see in the oral cavity?
We will see whether there is a adequate mouth opening is present, sir.
Okay.
And oral hygiene, sir.
Okay.
Whether any ulcers or swelling over the lips, buccal mucosa, floor of mouth, sir, or the retromolar trigone.
Yeah.
Yes, sir. And we'll also check for the, yes, sir.
Tongue lesions. Anything
yes,
in the tongue lesions. Tonsillar area.
Yes, sir.
Are the tonsils are normal? Is there any bulge in the tonsillar area? Or is there any growth or any infective thing in the tonsillar area? And the posterior pharyngeal wall.
Okay, sir.
And you have to palpate the tongue. For what?
To see if there is any growth in the posterior 1/3, sir.
Not growth. Growth is a conclusion. Examination is for some findings. So what is that you will appreciate in palpating the tongue? Look for any induration.
Indurations. Okay, sir.
Any induration you should look for. That is a finding. Growth is a conclusion.
Okay, sir.
Okay, you are examining the oral cavity. Okay, look for any induration in the tongue. Look at the tonsillar area for any growth or infective source in the tonsillar area. RMT area for any mucosal lesions. Buccal mucosa, any lesions.
Okay, sir.
Okay, it's really important to see all of these areas in the oral cavity in this case.
Okay, sir.
So anything was found in this case?
No, sir.
Nothing. Okay.
Nothing.
Fine. Next. Go to the axilla now.
Yes, sir. On examination of the left axillary region, fullness was seen in the left upper axillary region. There was the skin over the swelling was normal, and there is no discoloration in the axilla. No scars, sinuses, or dilated veins were present.
This all of you should stop this. No scar, no sinus business. If it is there, you should highlight. Otherwise, you should not mention that.
Okay, sir.
Okay. Palpation.
Yes, sir. Swelling measuring around 3 into 4 centimeters, which was ovoid in shape. It was non-tender. There's no local rise of temperature, and it was having a rubbery consistency, and it is mobile. Yes, sir.
Yeah, continue.
Yes, sir. The swelling was mobile, sir, and on examination of the right axillary region, fullness is seen over the right axillary region, and skin over the swelling was normal, sir. The swelling, which was in the right axillary region, was about 1 into 2 centimeter in size, ovoid in shape, non-tender, no local rise of temperature, had a rubbery consistency, and was mobile, sir.
So according to your axillary examination, she has swelling in the right axilla.
Right and left both, sir.
Both of same size, or 3 centimeter on one side, 1 centimeter on the.
Yes, sir. And the left axilla,
you think they are lymph nodes?
Probably yes, sir.
Probably yes. Okay, fine. Yeah. Anything else you examine?
Systemic examination, sir.
Okay.
Per abdominal examination, the abdomen is soft and non-tender. The umbilicus is central and normal in shape. There is no swelling around the umbilicus. There is no organomegaly, no scars, sinuses, or dilated veins over the abdomen. There is no signs of ascites. On examination of the external genitalia, it is normal and there is no evidence of inguinal lymphadenopathy. And on digital rectal examination, no mass was felt and perineum and anal canal were normal.
In the abdomen, in this case, keeping
Yes,
that
sir.
findings in the axilla and the neck in mind,
Yes, sir.
what is that you will examine in the abdomen? For what you will examine?
So we'll look for any nodule near the umbilicus, sir.
What is that you want to mention?
Sorry, sir.
What nodule? What nodule in the umbilicus?
Sister Mary Joseph nodule, sir.
Why in this case, 20 years lady? I expected you should look for hepatosplenomegaly because there is a possibility of lymphoma.
Yes, sir.
And you should examine for para-aortic lymph nodes enlarged.
Okay, sir.
Okay, these are the 2 points you should examine in the abdomen, keeping these
Yes,
things in mind. How will you
Okay, sir.
examine for para-aortic nodes in the abdomen?
So we have to see the position of this swelling. So if the para-aortic nodes are present, it will be just beside the midline, and it will not move with respiration, sir. And on knee elbow position, it will not. Sir?
Okay. Anyway, I don't know, but you should have mentioned epigastric mass left side of the midline.
Okay, sir.
Left side of the midline. Yeah, not moving with the respiration is accepted, but chest knee position is not accepted. Okay.
Okay, sir.
Okay, fine. That's all in the abdomen. All this scar sinuses again, just now in the previous slide I mentioned, and again you read this. Okay, next slide. Yeah, next.
On examination of the respiratory system, bilateral air entry was present. No dilated veins over the chest wall. No dullness over the sternal and parasternal areas on percussion. Normal vesicular breath sounds were heard on auscultation.
What was your intention of examining respiratory system in this case? What was your intention?
So if there is any presence of mediastinal lymph nodes, sir, there would be dullness on percussion, sir.
One. Anything else?
If it is a benign swelling like a plunging ranula, or if there is any SVC obstruction, sir,
no. See, don't make things complicated. This particular case where you have small swellings on either side.
Yes, sir.
Make it simple. One, you said mediastinal associated mediastinal nodes. I'll percuss and look for dullness accepted. Anything else in the chest you would like to examine? This case. Right. In other words, I am asking you for evidence of tuberculosis, anything you will examine in the chest with the keeping tuberculosis in mind.
Yes, sir. If there is any skin rashes over the chest wall,
chest is respiratory system. Involvement of respiratory system by tuberculosis, clinical examination, what is that you will be doing?
There will be hollowing of the supraclavicular spaces, sir.
Okay, indicating
loss of the apical mass, sir.
What is that called? Tuberculosis, what is that? Collapse of the apical lobe.
Collapse, yes, sir. Fibrosis of
collapse, consolidation, collapse. What else? You look for bronchial breathing.
Yes, sir.
What? Indicating what? If there is a bronchial breathing in this lady.
If there is a bronchial
air entry.
Yes, sir. It may a shift of the trachea towards the side of fibrosis.
Okay,
sir.
One shifting the trachea.
Yes, sir. If there is a bronchial breathing, if the nodes compress over the bronchus, sir, there may be bronchial breathing, sir.
No. When if it is a surgical case, we should have some knowledge of medical entity because our first suspicion is tuberculosis. So we should know what are all the tuberculosis findings in the chest examination. One, you said tracheal deviation, like inspection, palpation, percussion, auscultation. Tracheal deviation, decreased chest movement on the affected side, crowding of the ribs on the affected side, decreased air entry on the affected side, dull note over the affected side, bronchial breathing on the affected side, decreased air entry with a dull note indicating pleural effusion, You understood?
Pleural
Shifting
effusion,
of the
yes, sir.
mediastinum in pleural
Yes,
effusion.
yes, sir.
Yeah, tuberculosis, everything we should know about tuberculosis. What are the chest findings?
Oh,
Okay, this case may not be anything in
okay,
the
sir.
chest, but if it is asked, we should be tuberculosis, nothing, no single question should be unanswered. Clinical examination. Okay. Okay, fine. Next slide.
Summary, sir.
Yeah, fine. Now you let me know anatomically what are those neck swellings are.
First, we'll suspect a lymph node swelling, sir.
No, don't suspect. You have presented a case. You have photographs in front of you.
Yes, sir.
Okay, what are anatomically those two swellings are?
It is a lymph node swelling, sir.
Lymph node swelling. Which group of lymph nodes on left side and which one on the right side?
On the left side, it represents the upper jugular lymph node, sir.
Okay, level 2 lymph node.
Level 2. And
Is
on
it
the
a
right
single
side,
node? Is it a single node or a matted node?
a single node, sir.
Single. Why do you say it is single, not matted? In your clinical
There is no
examination?
evidence of matting, sir, because there was discrete.
No, you cannot say there is no evidence of matting. It will not tell us that, hello, yeah, Akash, I am not matted. Like that, it will not tell you.
Yes, sir.
You should mention your clinical examination findings to say that, yes, there is no matting.
Okay, sir.
What is the surface? Surface.
Smooth surface, sir.
That is why it is not matted. It is single
Yes, sir.
node because
Yes,
surface is smooth.
Yes, sir.
It is. Why do you say it is discrete? Because it is mobile.
Mobile, sir.
Yeah, it is mobile and discrete and a single node. Does it matter to know these clinical findings?
Yes, sir.
Why?
Uh,
How does it matter? Because it will tell us the disease, what is the pathology inside these clinical findings.
Because-
You got the point. These clinical
Yes, sir.
findings tell us that what is the underlying, unlikely that it is an inflammatory disease. You understood? These
Yes, sir.
findings tell us it is unlikely to be an inflammatory disease
Inflammatory
because it is
swelling.
mobile, unlikely to be an inflammatory disease.
Yes, sir.
Okay, what is that right side neck node? Group.
It was in the posterior node, sir, probably a level 5 lymph node, sir.
Why probably? If it is posterior, it is level 5 only.
Level 5. Yes, sir.
Why probably? Is it not? They have
Yes,
been leveled, no? Already leveling
Yes, sir.
has been done. So you have to put that in your case.
Okay. Yes, sir.
Okay. So patient has got level 2 node on the left side, level 5 on the right side, which are discrete, mobile, with a smooth surface.
Yes, sir.
Okay. What in the axilla, which group they are?
In the left axilla, since it is involving the upper, central nodes are involved, sir.
Central node. Left, right side.
On the right side, the lower parts.
Tell us group, anatomical group. You cannot say either you should take the level
sir.
or you should take the group.
At posterior level, sir.
Posterior level. Either it has to be a posterior group of lymph nodes or it is a level 1, 2, or 3 in the axilla.
It is a
If it
posterior
is
group, sir. That was not posterior level, posterior group. Yes, sir.
Posterior group. Okay. That is also single or a matting is there?
It was single, sir. Smooth surface.
Single, mobile. If I say
Yes.
in a female there are axillary nodes, what is that important organ you should be examining and giving a comment?
The breast, sir.
Yeah, breast examination, which you did not mention. It was written but not mentioned.
Yes, sir.
Okay, you have to palpate the breast and look for and highlight is there any lump in the breast or not. Even patient is 20 years.
Yes, sir.
Okay.
Yes, sir.
Fine. So any other examination you have done?
No, sir.
Fine. What is the diagnosis now?
My provisional diagnosis is that it is a case of generalized lymphadenopathy, probably due to a primary malignant lymphoma, sir.
How did you conclude that this is a case of generalized lymphadenopathy?
So because it involves two contiguous groups of lymph nodes.
Okay, more than 2 or more group of nodes involvement,
yes,
we label them as generalized lymphadenopathy, and they should be significant nodes.
Significant, yes, sir.
Okay. And pathologically, you think in terms of lymphoma?
Yes, sir.
Okay. Anyway, for undergraduates, we accept you should not use this primary malignant lymphoma. Is there
Okay, sir.
anything called secondary malignant lymphoma?
No, sir.
Huh?
No, sir.
This is how you invite problems. Yeah, probably I'm thinking in terms of Hodgkin's lymphoma.
Okay, sir.
Okay, because why do you think it is lymphoma in your clinical examination?
So because the swelling over the cervical regions and the axillary region, it was single, mobile. It was a single and discrete, mobile, having a smooth surface, sir.
One. Same findings in the axilla also.
Yes, sir.
Any other points in your case to say that it is likely to be a lymphoma? Any other points?
It involved the cervical lymph nodes first, sir. Then it has progressed to the next.
Agreed. In your case, any other points in favor of lymphoma? Which is the commonest cause for lymphadenopathy in our country?
Tuberculosis, sir.
Tuberculosis.
Yes, sir.
So here patient has been treated. Even
Yes,
though it is
sir.
not a complete treatment, without any response.
Yes,
okay. So possibility of lymphoma is always there. And your description of the nodes are typically fits into lymphoma. Why do you think it is a Hodgkin's? Why not non-Hodgkin's?
Because the age of the patient, sir, the Hodgkin's lymphoma will have a bimodal incidence, sir.
Okay.
And there is no involvement, there is no presence of hepatosplenomegaly, sir.
No visceral disease she has. Okay,
yes,
only lymph node disease.
Yes, sir.
Young patient and a lymph node disease.
Lymph node disease.
With that description of the node. So
yes,
that makes the possibility of Hodgkin's lymphoma.
Yes, sir.
Okay.
Yes, sir.
Okay. You would like to give any secondary deposits in the node? Any possibility?
There is
you should mention the answer should be unlikely because she don't have any symptoms or the signs which you have examined of primary malignant disease. Patient is very young and the possibility of lymphoma is more than secondaries.
Yes, sir.
And your examination findings of the lymph nodes are typically fits into lymphoma nodes. Okay, just because we have asked, don't keep a possibility of secondary deposits in this.
Yes, sir.
Okay.
Yes,
if I say in the neck, taking only the neck nodes, level 2 or 3 neck nodes in this patient, same age group, if I say give one malignancy where there can be secondary deposits in the neck nodes, what is that malignancy you'll be thinking in terms of in the same age group?
A tonsillar malignancy, sir.
No, they are not common in young age, 20 years. Thyroid cancers can happen in the younger age group.
Okay, sir.
Okay. Level 3 nodes if a patient has, and I'm asking you what is the likely primary thyroid cancers can have in a younger. Okay.
Yes.
Fine. How will you proceed with this case?
We'll do hematological investigations, sir, first.
Okay.
We looked at her hemoglobin. It was about 11, sir.
You have the report here in this slide?
No, sir. I haven't attached the reports, sir.
Fine. Then you don't mention it was about 12 means what? If you have seen the report, it will be 12 only, no?
Yes, sir.
Huh?
I've attached the ultrasound report of the abdomen and the neck, sir.
Okay. Anything else in the blood investigation?
She had raised ESR, sir.
Okay.
Yes, sir. Apart from that, there was no positive.
No, what else you would like to do in the blood?
We look for lymphocytosis, sir, if there is lymphocytosis is present or not, sir.
Okay.
And the total count, if it is raised more than 15,000, it is a poor prognostic indicator, sir.
In what?
Sorry, sir?
For what? Poor prognosis. You are not diagnosed the disease still.
Yes, sir.
So in blood, what else?
In case of Hodgkin's lymphoma, it will be a poor prognostic indicator, sir.
No, you are not diagnosed. No, still you are not diagnosed. How will you predict the prognosis now?
Okay, sir.
Okay. In the blood, what I wanted was peripheral smear.
Peripheral smear. Okay, sir.
Sometimes leukemias may mimic lymphomas. So by doing a simple peripheral smear, you will see the abnormal cells and you can diagnose leukemias.
Yes, sir.
You can diagnose leukemias. So have a peripheral smear. Okay, leukocytosis may go in favor of tuberculosis also.
Yes.
Lymphocytosis. Yeah, it may go in
Yes, sir.
favor of tuberculosis also. Okay, what is the specific investigation for this lady?
Ultrasound, sir. And
Okay,
on ultrasound examination, she had multiple subs. Shall I read out the reports, sir? Or?
no need. Just mention. They have mentioned bilateral neck nodes.
Yes, sir. And
Okay,
those
axilla
are,
also they have mentioned bilateral nodes.
yes, sir.
Okay, abdomen, what is that they have seen in the abdomen?
Significant abnormalities, sir.
Nothing they could see. So again, in the abdomen ultrasound, they should look for liver, spleen, and para-aortic nodes and iliac
Yes.
nodes. Okay, what is next now? So now on ultrasound, you have found out that she has got multiple neck nodes and axillary nodes.
Yes, sir.
So how will you histologically confirm the diagnosis now?
We have to do a FNAC, sir.
Okay, FNAC will give the diagnosis.
No, sir. If the FNAC is inconclusive, we have to go for an open excision biopsy, sir.
Okay, which is more ideal in diagnosis of lymphoma? Is it FNAC or lymph node biopsy? Complete lymph node biopsy. Huh? Which is ideal, FNAC or complete lymph node biopsy?
Complete lymph node biopsy is ideal, sir.
Why?
So because FNAC may alter the presentation, sir, may alter the structure of the lymph nodes. Sir.
No. FNAC will not alter the structure. You see, we need to have one diagnosis, second grading of the tumor.
Great. Okay, sir.
So that cannot be done with the FNAC.
Okay, sir.
Okay, always it is complete unaltered lymph node we want for lymphoma diagnosis.
Yes, sir.
Without much manipulation of the lymph node while doing biopsy.
Yes,
okay,
sir.
Complete lymph node we need to take out and send it for histopathology, one for the diagnosis, second for grading of the tumor.
Great. Yes, sir.
Okay, so lymph node biopsy is a must. Which lymph node you will do biopsy in this case?
Cervical lymph nodes, sir.
Cervical. Which right one, left one?
The left one, sir, because it is more in size.
Why not right one? Yeah, whenever you have cervical nodes and the question is asked for biopsy for a particular diagnosis,
yes, sir.
We should avoid posterior cervical nodes. We should avoid.
Okay. Okay.
Sometimes these lymph nodes are maybe because of the infection in the scalp.
Okay.
Okay. So if it is a level 2-3 nodes, they become a significant nodes.
Okay, sir.
If the option is between submandibular, submental, and level 2-3 nodes, again we should go for level 2-3 nodes, because submental and submental, that is level 1 and 2, level 1 nodes may be because of oral infection.
Yes.
So once you do biopsy, you should get the diagnosis. That is the impression.
Okay, sir.
If there is an option between posterior cervical and axillary, option is between the posterior cervical and axillary, we should opt for axillary node biopsy.
Okay, sir.
So they will have a specific disease.
Okay, sir.
You got the point. That is how we should choose the nodes. These questions will be asked.
Okay, sir.
So by doing a biopsy, we need to. So if it is level 2, 3, 4 nodes, that is deep cervical group of nodes, they will have a specific diagnosis. So better choose them. If they are not there and posterior cervical or level 1 nodes and axillary nodes, prefer the axillary node.
Okay, sir.
Okay, that is how we select which nodes to be biopsied.
Okay, sir.
Okay. So what is that histologically they will see on Hodgkin's lymphoma? The pathologist?
The Reed-Sternberg cells will be
the Reed-Sternberg cells. Okay. Which one the clinician will be happy to treat? Is it HL or NHL?
So Hodgkin's lymphoma, sir.
Why?
Because it has a better prognosis, sir.
Compared to NHL.
Compared to NHL.
And NHL is a visceral disease.
Visceral disease, yes, sir.
Yeah, they can have a visceral involvement in the form of liver, spleen, or lung.
Yes, sir.
Okay, they carry poor prognosis. Okay. Kishan? Hello, Kishan?
Yes, sir, I'm here. Kishan, sir.
I think that should be enough for the undergraduates. Treatment and other things Akash, any idea how this HL is being treated?
So for the early stages, it is radiotherapy, sir.
Okay.
In by radiation, mantle radiation, and if it is infradiaphragmatic, it will be inverted Y, sir.
Okay.
And in the advanced stages like stage 3 and stage 4, chemotherapies such as ABVD regimen and MOP regimen is used, sir.
Okay. Any idea about how it is being classified? Yeah, you should check whether it is above the supradiaphragmatic or infradiaphragmatic disease. You
Yes,
should
sir.
find out. And depending on that, once the disease becomes infradiaphragmatic, then probably you have to select the chemotherapy as a first modality of treatment. Okay.
Yes, sir.
And if
Yes,
the
sir.
patient is young, giving RT also will have its own consequences. Like you
Yes,
said,
sir.
if it is a cervical or supradiaphragmatic disease, RT may be one of the. Can I share, just I wanted to show about a few photographs to these students. Can I share the slides?
Yes, sir, you can share.
Share screen. Is it visible now, my slides?
Yes, sir.
Is it visible?
Yes, sir. It is visible,
Yeah.
sir.
Yeah.
Yes,
Cursor also
can
is
you-
visible. Cursor also is visible.
Cursor is not visible, sir.
Now?
No, sir.
Okay. Okay. Fine.
You can switch into a full screen, sir.
Switch into
Full screen, sir.
full screen. It is full screen only now. In my tab, in my laptop.
Okay, sir.
It's not full screen there.
No, sir.
It is full screen in my laptop. Now?
No, sir. It's still the same, sir.
Yeah, here. Okay,
Your
anyway.
cursor is now visible, sir.
Yeah. What I wanted to highlight for you people at undergraduate level, whenever you present a case of cervical lymph nodes in general, presence of scar and sinuses, if you can see in both the photographs, if it is there, you highlight. In this case, yeah, definitely it is going to give the diagnosis by highlighting. If you see these sinuses. And if you see this erythema over the summit of the swelling, if it is like this, you should highlight. Okay. So you should, obviously there are findings. Okay. So in this case, you need to highlight these points. And in the palpation, you should highlight how the node is fixed here, about the mobility you need to comment. And is there any discharge while palpating this node during this, through this sinus, you should highlight. Just to show these two different age groups, like I was mentioning posterior cervical and anterior cervical for your case, if you can see here, between the two nodes, there is a gap. You can see on inspection, at this point you need to highlight. In palpation, that becomes a discrete nodes. There are discrete multiple nodes. That becomes an entity here. So in inspection, you should highlight there is a gap between the two swellings. There is a line of swellings all along the length of the sternocleidomastoid, and between these two, there is a gap, indicating they are discrete nodes. In a old AD like this, left side, if you see here, it's a lower deep cervical, this swelling. Okay. So like I mentioned, no site of the node makes, for example, this lady, old lady, 60, 70 years with a right lower neck swelling, it is malignant deposit unless otherwise proved. Straight away it goes into. In a young fellow who has come with a history of swelling for long duration all along the length of the neck, it is lymphoma unless otherwise proved. So the one sentence by mentioning where exactly and how exactly you are going to give the diagnosis. That is why it is important to mention. Few more the photographs, like if you mention here all along, young middle-aged fellow coming like this, keep a possibility of lymphoma again. All these cases. All these cases. Here, this lateral on either side, you can see the upper one, right upper one, multiple on either side. Okay. The last corner swelling, if you see this, straightway it fits into submandibular swelling. And one important point, submandibular swelling, whenever you have a case like this, your examination is incomplete unless you highlight the bidigital examination of this swelling. You have to have a bidigital to know whether it is a lymph node swelling or a submandibular gland swelling. That is the importance of knowing this, where exactly is the swelling.
Yes, sir.
Just I have put one video. If it plays, it will be helpful for you people. Are you able to see the video?
No, sir.
Video is not seen?
No, sir.
Okay, I don't know. Anyway, it was an examination, how to examine for the mobility of the swelling. Okay, I'll just try one more. Now?
Yes, sir. You can
Yes,
play
sir.
the video.
It is seen now?
Yes, sir.
Video is seen, sir.
Yeah. So this is what discrete mobility, irrespective of, like, in spite of having such a long nodal mass, you are able to move the node discretely. That's what you need to examine. Are you able to see that? So you should
Yes, sir.
describe that in palpation. Okay, fine. So with this, Kishan, madam, what this? Anything else, Akash?
No, sir. Thank you, sir.
Okay, anyway, we cannot have a complete discussion at this given time. What I insist for all the students who are attending to this, one, you should have a nice history to find out what is the anatomical source. Is it a node or something else? Second, to know the likely pathology. Is it a benign or a malignant, and a primary source? And third, in the examination, you have to highlight what level nodes are involved. And in the systemic examination, look for generalized lymphadenitis and visceral involvement in the form of spleen, liver, and para-aortic nodes. And once you give the systemic examination, I have highlighted in the presentation that what exactly you should be looking for. And
Yes, sir.
keep a possibility of tuberculosis first, and accordingly you find out history and examination. In the lymph node disease, in the other pathology, it's a lymphoma, which is the commonest disease you should look into. And in other middle cervical, keep a possibility of thyroid cancers also as a possibility. Okay. So once
Yes,
you have
sir.
a diagnosis, in the diagnosis, you should keep blood examination, then imaging, which I did not go into the depth. Imaging, in that ultrasound, CT scan, and other modalities has got their own indications, and few points regarding the treatment once you confirm the diagnosis.
Yes, sir.
Okay. Overall, it was good, Akash. Overall.
Thank you, sir.
Thank you.
Sir.
Thank you.
Yes, sir. Thank you
Yeah.
so much. It was indeed a very comprehensive and interactive class, sir. And the discussion was very useful for us. Thank you so much for teaching and guiding us, sir. We are ever grateful to you and need your blessings and support throughout, sir. Thank you so much.
Thank you.
And it
Thank you
was
so much,
also a great effort by the presenter. We could learn a lot because of your well-prepared presentation, doctor. So thank you
ma'am.
to you also. And
Thank
we
you,
also thank all the participants who were enthusiastically participating in this discussion.